Dr. Ken Landau. Thanks for watching. Let's talk about sleeping pills. Right now in the United States, about 9 million people suffer from insomnia. About 4% in people around age 20 to 30. Rises to about 6% in people in their 50s. About 7% in people in their 80s. It's much more common in Caucasians than it is in Hispanics and African Americans. Estimated that a third of the population gets less than the recommended 7 hours. Half of the population is occasionally going to have difficulty sleeping, including about a quarter of all kids. But somewhere around 6%, 7% going to suffer from chronic insomnia. That's in the millions. It occurs 50% more often in women than men. It occurs 50% more often in older individuals than younger people. It's estimated that there are 60 million or more prescriptions written for sleeping pills in the United States, and in Great Britain, 1 in 10 people take sleeping pills. Now, everybody has difficulty sleeping once or twice a month from stress or worry, but chronic insomnia is a condition that occurs 3 times a week for at least 3 months, takes at least 30 minutes to fall asleep, you get less than 6.5 hours sleep, and it causes difficulty in your working relationships, difficulty for you and your job. So sleeping disorders can be differentiated into difficulty falling asleep, difficulty maintaining the sleep, and difficulty getting restorative sleep. It's multifactorial, and it's important to realize a pill will not cure the problem. Now, we can conceptualize sleeping disorders as having a predisposing factor, a genetic factor that either makes you more or less likely to have sleeping problems, and then a precipitating factor that makes the genetic factor become obvious. That's some kind of a triggering factor, like a letter from the IRS, and then a perpetuating factor, something that makes your sleep problem just seem to persist. Now, genetics are extremely complicated. It's estimated that somewhere between 1.25% of adults have some genetic proclivity toward sleep disorders, toward insomnia, and there are many, many different kinds of genes. Peculiar names like clock and timeless and PER2 that reacts with stress, or PER3 that reacts with alcohol. And there are the serotonin genes and the GABA genes and the orexin genes and the adenosine genes. There are genes that cause the neurons to be hypervigilant and some to cause them to be slow. Some genes are important for sleep latency and others for sleep efficiency. And then we have the epigenetic factors. Factors that either tell the gene to turn on or turn off. Well, what are the precipitating factors? So you have the genetic underlying problem or potential for a problem, and then you get the letter from the IRS, you get the depression or a sleep situation. Somebody wakes you up in the middle of the night, or maybe you have to get up to urinate, or you have hot flashes or fibromyalgia, or you get reflux esophagitis. All of those situations, including health problems. You have heart disease or lung disease or arthritis, and it's painful, and that gets you up. And then maybe you're taking a medicine. Maybe you have a cold or an allergy, and you take a decongestant. That'll keep you up, and pain medicine, and prednisone, and asthma treatment, and beta blockers, and alcohol, and of course caffeine. Caffeine, an example. So many people drink coffee or have soda. It increases the sleep latency. It increases the stage 1 and 2 sleep, but it decreases your slow wave sleep, your total sleep, your effective sleep. Why? Because it works on the adenosine gene. Some people have it, some people don't. That's why coffee affects some people and it doesn't affect other people. And then the perpetuating factors, the problems with your sleep hygiene. You don't go to bed at the same time, you exercise right before you go to bed, you eat before you go to bed, it's noisy in the room. Maybe you're sitting watching the television, or you're getting the blue light from the computer screen, or it's noisy, or you took a nap. Well, all of those situations seem to be very important. So sleeping pills, that's a generic term. Okay? They're the over-the-counter sleeping pills, or prescription sleeping pills, and the complementary and alternative therapies. Hypnotics help get you to sleep, while sedatives just make you more relaxed and able to sleep. Now, The Agency for Healthcare Research and Quality, they say cognitive behavioral therapy is the best. But this takes time. You need 3 to 6 one-hour sessions. Helps about 3/4 of the people fall asleep somewhere between 12 and 40 minutes faster. Works even if you have certain other kind of disorders. Maybe you have PTSD or depression or alcohol dependency. But unfortunately, there's what we call the publication bias. It seems like only the beneficial studies get out into the literature. So let's talk about the pills. Okay? Over-the-counter sleeping pills. Probably 1 in 5 people take them, and 1 in 5 of those people take them for long term, 40% for more than a year. These can cause problems. These are antihistamines, and they can cause constipation and next day drowsiness. They can cause dizziness. These are pills that contain diphenhydramine, the same thing in Benadryl, or doxylamine. These are the pills that you get with the Advil PM or the Nitol or the Sominex or the Tylenol PM or the Unisom, or even the Z-Quil. The prescription medicines, the 1890s, with chloral hydrate, 1900s, with the barbiturates, phenobarb, secabarb, then the 1950s with Placidil, and then we moved into the modern era with the benzodiazepines. They call them the BZs. They were in the 1970s, followed in the 1980s by the non-benzodiazepine. We just call these the Zs. They're extremely popular. They're supposedly safer, but a lot of studies, including a lot from Europe, say, nah, they're basically the same thing as the benzodiazepines. Then we have some other kind of medicine. So the general function of the sleeping pill is to get you to sleep, but unfortunately, they don't work as well as described. And they certainly don't seem to work very well on a long-term basis unless you have a genetic proclivity. Well, if we look at the amount of extra sleep, it's 8 to 20 minutes that get you to sleep a little bit better, but they have some side effects, and the side effects can be drowsiness or dizziness, or in the next day you can be unsteady, you have an increased likelihood of falling if you get up at night to go urinate, or even if you get up in the morning, because they have a long-term effect and they can make you dependent. You should not take a sleeping pill. Repeat, you should not take a sleeping pill if you don't have 6 to 8 hours to be in bed. Now, the dose has to be lowered for the elderly and for women specifically. If we're talking about the benzodiazepines, they should be taken in the lowest possible dose, obviously. If you can take them for just 2 to 4 weeks because you get rid of the precipitating factors, you're sleeping in a quiet room, that's the best. On the other hand, if you have to take the sleeping pill, we know that they increase the non-deep sleep. They decrease the time to get to the REM sleep, the important sleep, and they decrease the total amount of REM sleep. And when you stop taking them, you can have some problems. Well, sleeping pills in the benzodiazepine or the Z family differ in onset and duration and price. We have benzodiazepines that are very short-acting. They can work within 5 or 10 or 15 minutes. Then we have medicines like Sonata, that would be in the family, or Intermezzo, that would be in the family. We have the short-acting drugs. These work in less than half an hour. That would be Halcion or triazolam, Ambien or Zolpidem. Now we have Ambien CR, and we have Melatonin, and we have Restoril. In the benzodiazepine family, for the duration, for the intermediate family, we have drugs like Lunesta and Restoril and a related compound that's different kind of chemical called Belsomra. And then we have long-acting medicines like doxepin and Dalmane that not only help you sleep tonight, but they help you sleep all day tomorrow and oftentimes into the next day. In the 1960s and 70s, that's when we got the benzodiazepines, the most popular of which are the Halcion triazolam, or the Restoril, which is temazepam. There are several others that are available. In the Z family, there is Lunesta and Ambien and Sonata. They're called the Z's because the generic name all begins with a Z. Now the Z's have different structure, but they work exactly the same, and they don't seem to have any practical difference from the typical benzodiazepines. For instance, if we talk about Ambien, it works exactly the same way that the Halcion and the Restoril and the other drugs works on the same receptor, but the government in 2013 said, you know, we ought to reduce the dose of the Ambien down to 5 milligrams for women. Men can take 5 or 10 milligrams, but women ought to take just about 5 milligrams because they're having increased incidence of motor vehicle accidents in the morning. And actually, in a woman who takes especially the 10 milligram dose, going to have about the same incidence of motor vehicle accidents as somebody who has been drinking. And about 4% of the people were dozing off. So these drugs, good for getting you to sleep, but they're not necessarily good unless you take the controlled release form for keeping you asleep. Sonata is another one of the Z's that helps get you to sleep, but won't do anything more than that. Lunesta, well, now they say that you should take a max of 1 milligram or maybe 2 milligrams, but the 3 milligram dose that was popular once upon a time not only caused metallic taste, but also kept you sort of groggy for up to 11 hours. Unfortunately, we don't have any comparative studies to show which of the sleeping pills seems to be better, but we know all of the classes that I just mentioned seem to work about the same. Then we have the sedatives in the benzodiazepine family, and some people use them. They would use drugs like Ativan or Xanax or sometimes Librium or Valium. Those are long-lasting drugs, probably not appropriate and can cause some significant problems and can cause some dependence. If we look at the sleeping pill, it's estimated that about half of the people to maybe 3/4 of the people who have chronic insomnia can take sleeping pills, and somewhere between 1/2 and 1/4 of them are going to benefit. Now, unfortunately, they have some side effects. Side effects would be cognitive changes, behavioral changes, complex sleep-related behaviors, and driving impairment. And if we look at the side effect profile, according to the Agency for Healthcare Research and Quality, the studies have been really not able to show a whole lot of side effects. A lot of people talk about some side effects, but there don't seem to be all that many, except for those that everyone agrees on, like these complex behaviors, the parasomnias, where you can be asleep, but you can eat or drive a car or walk or have sex or make a phone call, and you don't remember anything about them. That's a problem with some of these sleeping pills. And they can potentiate memory problems. So especially in older people who are starting to lose some of their cognitive function, these are not good pills. If you have learning problems, again, not good, or chronic obstructive lung disease, not good. And they can cause a rebound in insomnia, especially if you're stopping long-term Ambien or Lunesta. Additionally, they can cause next-day drowsiness. Some of them cause some weakness or impaired coordination, or sleepiness, or confusion, or amnesia. We know that people who take sleeping pills have a somewhat increased incidence of going to the emergency room, and as I mentioned, sometimes they leave an unpleasant taste in your mouth. If you take a sleeping pill, you can oversleep, you can have delayed reaction time. That's a problem with driving the next day. And certainly they're dangerous when you combine a sleeping pill with either alcohol or an opioid, or if you just are taking an antidepressant or an antihistamine, or you happen to be an older individual. Now, there are other kinds of sleeping pills that are not in the benzodiazepine family or the Z family. That would be a medicine, for instance, like Belsomra. I wouldn't take that one because the recommended dose is 5 to 20 milligrams, but it seems that it doesn't really work well until you take 30 to 40 milligrams. Works on a completely different pathway, has a lot of drug side effects, interactions, probably not the best. Then you have doxepin or Sinequan. This is an antidepressant. It blocks the histamine receptor. For sleep disorders, it's used at a very low dose, 3 to 6 milligrams. For an antidepressive effect, it takes about 25 to 150 milligrams. There's another one called trazodone that's used, but there's little evidence to use that, and even less evidence to use something called Advil or amitriptyline that has an awful lot of other side effects that could cause confusion or delirium, side effects that can cause urinary retention and constipation. And then there are other antidepressants like Remeron, probably not the greatest pill for sleep disorders. Melatonin, a lot of people take melatonin. If you're going to take it, you take it a couple hours before bed. You don't take it at bedtime, because if you take it at bedtime, it actually could disrupt your sleep. No potential for abuse. Has some kind of side effects in certain individuals. Doesn't seem to be terribly strong for some, but it's okay. There's a type of melatonin, a derivative known as Restoril. It's expensive, no good reason to use it. And then there's Halcion that's horribly expensive. That's for non-24. That's really just another fancy melatonin. And then there's light therapy, shining bright light at the appropriate wavelength, especially in elderly individuals in the evening, seems to be quite helpful. There are alternative therapies like kava or passion flower. There's St. John's wort and valerian. Some people take tryptophan or chamomile tea. Some people take lavender, or enzyme CoQ10, or skullcap. But there's no really good evidence that any of those work. Placebo effect, probably. And as a matter of fact, a placebo seems to help, so almost any kind of pill. Well, how much do these things cost? If you're going to take Ambien, you can get a generic Ambien, Zolpidem, for about 20 cents a pill, or $19 if you buy the brand name. If you're taking temazepam, which is generic Restoril, that'll cost you 30 to 60 cents a pill. But Restoril, one pill, $35. You can see here's a picture of 300 generic Restoril called temazepam, cost the same as one pill of the trade name variety. There's Lunesta, cost about $1 a pill. Restoril costs about $11 a pill, same for Balsamra. And the worst one of the bunch, Halcion, cost you about $455 a pill. Stay away from that one. So anyway, sleeping pills, good or bad? The answer is both. Sometimes they work very good, short term, depending on what else is happening in your life. But if you have a genetic proclivity, sometimes people need long-term use. On the other hand, if it's a problem because of some precipitating factor, and you get rid of the stress or you get rid of whatever is causing the problem, and if you have appropriate sleep hygiene, then maybe just a couple days or a week worth of a sleeping pill might be good for you. Anyway, thanks for watching. I'm Dr. Ken Landau.